Okay, Assalamu alaikum everyone. My name is Yazan Almasry. I'm an intern, and today I'm going to be doing a micro review for the renal block. So let's get started, inshallah. Okay, so first of all, I'm going to be covering some concepts and then move on to more questions and then more concepts. You get the point. Um, I'll try to make this lecture not as boring as it is. And lastly, if you find any difficult questions in AMBOSS, specifically AMBOSS, uh, please do not freak out. Sometimes it's not like the level of the questions that the uni will ask you. Okay, let's start by talking about UTI. And the first thing I want you to know, whenever you hear the word UTI, I want you to think of E. coli. E. coli is the most common cause of all spectrums of UTI. There are a few exceptions that we're going to be discussing in this lecture, but if you ever get stuck and you're asked about a UTI question or a prostatitis question, always ask her E. coli if you don't know what's the organism that's causing. Okay, some epidemiology. This lecture, I wouldn't focus on anything except this point, basically. Um, I mean, not this lecture, this slide, sorry. So, throughout the most of their lifetime, women suffer far more attacks of urinary tract infection compared to men. Why is that? Because women have a shorter urethra compared to men. Okay, so if you have a shorter urethra, you have a higher chance of infection because you have an easier access basically into the urinary tract. Okay. The second thing I would know from this slide is that the infection of in the urinary tract is depending on the confined site of anatomical site. What this means is basically all of these are urinary tract infection, but they have different names because it depends on the size that infection is infected. So, for example, urethritis is infection of the urethra. I'm not going to write it. You get the point. Cystitis, bladder. Pyelonephritis, kidney. So yeah, you get the point. طيب, and here you can see it. Okay, so we have upper urinary tract infection, which is the kidney and the ureter. So this area. And we have lower urinary tract infection, which is basically the bladder and the urethra. Okay. Which one is the worst out of all of these is pyelonephritis. Pyelonephritis is a very nasty diagnosis and it can lead to death in sometimes and sepsis. So just whenever you hear pyelonephritis, no, it's a really bad disease. That's why we always try to say like we want to treat early so it doesn't become pyelonephritis, because if it becomes pyelonephritis, number one, it's difficult to treat. Number two, it's going to be IV antibiotic, needs hospitalization. It's a very nasty disease. Okay, so how does it work? What's the pathogenesis? What I want you to remember here is that the first step in all of this is the attachment of the bacteria. So this attachment of the bacteria, okay, happens. It's called adhesion. Okay, and then they collect and form something called biofilm. So just remember, there is adhesion that's happening, then biofilm will happen, and this biofilm will allow bacteria to grow easily. Okay, again, always remember that the most common cause of UTI is E. coli. So if you ever get stuck, just remember E. coli. Anything else, like or special cases, will be discussed separately, but if you ever get confused and don't know what to answer, answer E. coli. Okay. Fungal agents, Candida albicans is the only like fungal agent you need to know that causes UTI. They will rarely ever ask this. Just know it's basically caused by Candida albicans if they ask you. So if they tell you there is a fungal infection of the UTI, just think Candida albicans. Okay. So let's focus more on E. coli. Okay, so what do we need to know about E. coli? We need to know that for E. coli to cause an infection, there has to be some adherence that's happening to the host cell or our body, okay? And this adherence happens on the receptors that are called uroplakins, okay? Uroplakins allows the E. coli's type 1 fimbriae to attach to it. Okay, so this type 1 fimbriae is attaching to uroplakins. Okay, so what I want you to remember is, I want you to remember something called type 1 fimbriae, which is a virulence factor for E. coli, and this allows the attachment to uroplakins. Remember uroplakins in case they ask you about it. Okay, and it's finally like uroplakins is found in like urethral surfaces, like the ureters, the bladder, the kidneys, urethra. You get the point. B. fimbriae, on the other hand, is a virulence factor that allows attachment to upper urinary tract pathology. So if you have pyelonephritis or they say upper urinary tract pathology, think of P. fimbriae as the virulence factor. All right, so how do we diagnose? So for diagnosis, we need to collect and send to the lab a urine sample. Okay? And this urine sample, whenever we say urine sample, I want you to remember the word midstream urine specimen. Okay, so whenever we say midstream, it means that it happens at the mid of the stream of the urine. So the first part of urine, basically we're gonna skip it. We're not gonna put it in the sample. The mid part, all the way to the end of urine, is gonna be known as the midstream urine. Okay. Sometimes we need to give urine culture, or we need to do urine culture, but it's just in special cases like complicated UTI, failed treatment, pregnant female, and you get the point. So normally the answer would be urine analysis, not urine culture, in case you get a question about this in clinical, because I remember they love to ask about this. The first step is urine analysis, it's not urine culture. طيب. So we have different types of urine samples, okay? We said we have the clean catch midstream urine specimen, okay, and this is the most common one and the one we probably have given, all of us probably have given at some point in our life. We have the suprapubic tap, which is used specifically for neonates. It's important to remember this. We have the catheter specimen, because patients on catheter, we're not going to remove the catheter and then ask them to give a midstream urine specimen. We're just going to take it from the catheter. And I'm going to discuss more on how we take a catheter sample. Okay, moving on to urine culture. Urine culture is very, very important to know these values that are in the table. So let's go one by one. So you take a urine sample, you culture it, okay? If we have a man or a woman that are asymptomatic, plus we have bacteriuria or growth of bacteria that's more than 10 to the power of 5 CFU per milliliter, that's positive, positive for urine tract infection. Okay, so that's the first case. The second case is if we have a woman that's symptomatic, plus we have 10 to the power of 2 growth of bacteria, that's also positive for UTI. The third case is if we have a man symptomatic plus 10 to the power of 3. Sorry, I'm just getting cold from Jamaica. I don't know why. Anyways, yeah, 10 to the power of 3. That's positive for UTI. And lastly, if we have catheterized urine and any type of with symptoms and any growth, that's basically positive. UTI, suprapubic aspirate, any growth or any condition plus any growth will lead to UTI. Okay, so let's repeat these. So the first one we said, I can't find my cursor. Where's my cursor? Oh, it's right here. Okay, so we said woman or man, asymptomatic, 10 to the power of 5 or more, that's positive for UTI. Woman, symptomatic, 10 to the power of 2, symptomatic, it's a UTI. Men, symptomatic, 10 to the power of 3 or more, it's UTI. Catheterized urine symptoms and any growth is positive for UTI. Suprapubic aspirate and any growth is positive for UTI. Please know this table. Okay, so how do we collect catheter samples? So first of all, we clamp the catheter. We flush, I don't know where it is, here it is. We flush the catheter urine and then we collect it from the valve, not from the urine bag. So let me say this again. When we collect a urine catheter, we collect it from the valve of the catheter, not from the urine bag. And the reason behind that is that in the bag, there is stasis of the urine, okay? And this stasis will lead to overgrowth of bacteria. So definitely the bacteria, like the sample will be positive. This is why we collect from the valve. Type. Other diagnostic approaches, urine analysis, which is very important. It's the most important initial step for the diagnosis of UTI. And what do we look for? We look for nitrate test. Nitrates, basically, if it's positive, it tells us it's bacterial infection. Leukocyte esterase test, which if it's positive, it tells us there is inflammation, and we look for the pH. Then we have microscopy. So for microscopy, what do we look for? We look for white blood cell count, and we look for white blood cell cast. White blood cell cast basically is for pyelonephritis, and we're going to get to that later. Okay, just assume I wrote pyelonephritis, مشوار. And we also do gram stain of the bacteria to know what type of bacteria that is causing the infection. But what mostly we focus on is the white blood cell count. So here it is, microscopy. Okay, so pyuria, which is basically pus in the urine, okay, or in other words, presence of WBCs in the urine, okay, because pus is produced by WBCs. It's a hallmark of inflammation. It not necessarily means it's a UTI, but it should be present if there is a UTI, okay? So every UTI has pyuria, but not every pyuria is UTI. And bacteriuria, which is presence of bacteria in the urine, and the magic number here is 10 to the power of 5. If you have 10 to the power of 5 or more bacteria per high power field or whatever they call it, then it's positive for UTI. Type. We have something that's called sterile pyuria. Okay, we said pyuria is inflammation or the presence of WBCs. Sterile means there is no bacteria. So it's basically we have a lot of WBCs, but there is no growth of organisms on culture. Okay? There are two main causes of this. Number one is genitourinary TB. And number two, it's chlamydia infection. Wow, what a two. Anyways, chlamydia infection. Why do we have chlamydia infection? Because if I remember correctly, chlamydia does not have a cell wall, so you'll not be able to see it on microscopy or gram stain. As for TB, it will take weeks and weeks for TB to grow. So when you take the sample initially, it's not going to show any TB. So it's going to appear as sterile pyuria. So remember these two, it's really important. Okay, next we're going to talk about specific classification of UTI. Okay, there are specific classifications for UTI, and we talked about some of them already. So for example, simple cystitis, which is infection of the bladder, is the most basic type of UTI. So whenever we say in the hospital this patient has UTI, we're most likely referring to a simple cystitis. We have ESBL infection, which is extended beta-lactamase spectrum infection, something like that. Anyways, we're going to talk more about that, which is also still cystitis, but it's a pretty nasty infection and very difficult to treat. We have asymptomatic bacteriuria, we have UTI in pregnancy, catheter-associated UTI, or COTI, and pyelonephritis. Okay, let's be more specific. Okay, starting with acute simple cystitis. So whenever we say UTI, usually it's referring to acute simple cystitis. Okay, and usually it happens when it's confined to the bladder. So it's an infection that's confined to the bladder. Some of the risk factors is a recent sexual intercourse and history of UTI, which is self-explanatory. History of anything in medicine increases the risk of that disease in the future, whether it's myocarditis, endocarditis, UTI, sepsis, whatever. Use of spermicides and like diaphragm and condoms, and use of spermicides alone. Type. Most common cause, E. coli. Very simple to remember. You don't know the answer, which bacteria? E. coli is the answer. Type. So how does the patient present? They will present mostly with dysuria, which is basically burning sensation in urine, and or burning sensation or pain with urination. Also, we have urinary frequency, which is basically going to the bathroom a lot. Urinary urgency, which is basically always feeling the need to go to the bathroom, even if you are not peeing. And suprapubic pain, which is around the bladder, which makes sense. If you have infection of the bladder, you're going to have pain around the same area. And sometimes you can have hematuria, which is blood in the urine. All right, so ESBL, we already mentioned it, which is the extended beta-lactamase uropathogens. These uropathogens are very, very bad. Why? Because usually they have resistance to the treatment. Okay, so beta-lactamase, so let me write this down. Beta-lactamase, what it does, sorry, is that it prevents cephalosporins from working. So So it prevents them from working. So if a bacteria has this, the antibiotic will not work. So we think we're treating, but the treatment is not doing anything. Okay? So here it is. So extended, it's basically beta-lactamases, okay, that hydrolyzes the cephalosporins. Okay, second and third generation. So usually when we have a UTI, how do we treat them? We give cephalosporins. If a bacteria is resistant to that, you can expect that the bacteria won't die and it will live for longer and more likely to cause complications. That's why it's important. Okay? So, what's the solution for this is we add a beta-lactamase inhibitor, which is clavulanic acid, for example. It's a beta-lactamase inhibitor, which basically will inhibit the beta-lactamase of the bacteria, allowing the cephalosporins to work again. Okay. Now, what I want you to remember from this slide, and it's really important, and you probably will be asked about it, is how do we know from culture if we have beta-lactamase activity or not? Okay, so this is a culture, okay, and this is without clavulanic acid, and this is with clavulanic acid. This scratching thing is the growth of the bacteria, and this area that's clear is no growth, and this area that's clear is no growth. Now, we can say that this area has less growth. With clavulanic acid, it has less growth of bacteria, which means that the antibiotic is working better, right? This area has more growth of bacteria, or a less clear zone, okay, which means the antibiotic is not working that well. Okay, so let me repeat that again. So if we have a larger zone of clearance, it's called zone of clearance, okay, it means less bacteria is growing here, which means the antibiotic is working better. If you have a smaller zone of clearance, which means that more bacteria is growing, it means the antibiotic is not working that well. Okay. Now, the magic number that we need to remember here is 5 millimeters. So if we add clavulanic acid, and the difference between with and without clavulanic acid is 5 millimeter, that means the bacteria that's there is ESBL. Okay, so let me repeat that again because it's really important. If we have a culture and the difference between the growth or the the clearance zone, okay, between cephalosporin plus clavulanic acid versus cephalosporin alone is more than 5 millimeters, then it's ESBL. Okay, remember that statement. If you can't understand that statement, just remember the number 5 millimeter and answer that in the MCQs. It's fine. And the picture as well. Okay, so what are some complications? And these complications happen for all types of UTI. Probably you'll see the same slide over and over again, which is recurrent infection, ascending infection leading to pyelonephritis and sepsis. But how to prevent cystitis? You can read this on your own. It's not that important. Or just read it on your own. It takes 3 seconds to understand. But the next entity is asymptomatic bacteriuria, and from the name, asymptomatic bacteriuria. So we don't have symptoms, but we have bacteriuria. And if you guys remember, we said if it's asymptomatic bacteriuria, what's the number? It's 10 to the power of more than 10 to the power of 5. Okay, and there is no organisms. There is 10 to the power of 5, more than 10 to the power of 5 of organisms, but there are no symptoms. Now, asymptomatic bacteriuria is really, really important in pregnant ladies. So whenever we have a pregnant lady who has asymptomatic bacteriuria, it's very, very important to treat. Let me see this. Okay, it's very important to treat asymptomatic bacteriuria. Why? Because it can lead to prematurity, low birth weight, stillbirth, and many other complications to the fetus. And this is why we do routine screening for females, because it's asymptomatic. The only way to find out is through screening or incidentally. Okay, so why do we have more UTIs in pregnancy? The reason we have more UTI in pregnancy because we have a lot of progesterone being produced. This is really important to remember. Physiological changes that happen with pregnancy that increase the incidence of UTI is due to progesterone. Okay, so what does progesterone do? It causes dilation of renal pelvis and ureter. It causes urethral paralysis to decrease and reduce bladder tone, all of which cumulatively will lead to less movement of the urine, more stasis, and more likely to become to have a UTI. So higher progesterone in pregnancy will lead to dilation of the renal pelvis and ureter, decreased peristalsis in the ureter, and reduced bladder tone, increasing the risk of UTI. Remember that. Okay. Okay, sorry. So then we have catheter-associated UTI. Okay, so for catheter-associated UTI, it's basically a UTI that happens because of the catheter, and most commonly happens in the hospital because that's where people with catheters are basically. Okay, now The most important thing to remember about catheter-associated UTI is the risk factor for it, okay, which is basically the duration, okay. So the longer the longer the catheter is there, the higher the chance it is that you have UTI. Okay, so if you have catheter for 5 days, there is a really high chance to get UTI versus 1 day, there is a really low chance of getting UTI. So if you're going to remember something, remember that catheter-associated UTI, the longer the catheter is there, the higher the chance of you developing UTI is. Okay, and again, the most common organism, as you have guessed, it's E. coli. I'm just searching for my cursor. Yeah, it's E. coli. Usually catheter-associated organisms are resistant to antibiotics, so it's more difficult to treat. But now, one of the important things to know about catheter-associated UTI, sometimes it's caused by Proteus mirabilis organism. So what's special about Proteus mirabilis? Proteus mirabilis has high activity of urease, okay? This high activity of urease will cause more formation of biofilm and formation of stratified stone. Okay? This stratified stone will lead to what? Obstruction of the catheter. So, to put it in summary, Proteus mirabilis is important because it has high urease activity. This high urease activity will lead to more stratified stone formation. Stratified stone formation will lead to obstruction of the catheter. Okay. Some of the signs and symptoms, we can have fever, suprapubic pain, just normal like UTI symptoms. And catheter obstruction, and mostly seen catheter obstruction is seen with Proteus mirabilis. So what's the management? Very simple. Remove the catheter because it's a source of infection and give antibiotic to treat the already existing infection. And how do we prevent it? We already mentioned this. To prevent catheter-associated UTI, minimize the use and the duration. Very important. If you want to avoid having a catheter-associated UTI, you want to minimize the use and the duration. And if you have to use it for a long time, you keep changing it, basically. All right. Same complications as other UTIs. Right. So then we have pyelonephritis. Okay. So one second. Okay. So for pyelonephritis, it's basically infection of the kidneys and the renal pelvis. It's a very nasty infection. It's one of the worst UTI you can have. It happens because of the ascending of the bacteria from the urethra to the bladder and then to the kidneys. Sorry. And less commonly, it can happen hematogenous spread. So if you have infection anywhere else in the body, you can have infection of the kidney as a result of it, leading to pyelonephritis. Okay, so what are the symptoms, presenting symptoms of pyelonephritis? Usually pyelonephritis happens due to flank pain, or actually pyelonephritis presents with flank pain plus fever. Okay, so whenever you have flank pain plus fever, it's pyelonephritis until proven otherwise. One thing I want to add is that usually they will mention that there is a WBC cast. WBC cast is very specific to pyelonephritis. Okay, so also you can remember that if you want to like just remember 3 facts about pyelonephritis. Remember WBC cast, flank pain, and fever. And as you have guessed, E. coli is the most common pathogen that's causing pyelonephritis. And here I say it's actually for all UTI spectrum, and I mentioned it like a million times by now. Type. One of the special cases is Pseudomonas aeruginosa, where it's more common than E. coli. Pseudomonas aeruginosa is more likely to cause UTI in patients with anatomic or neurologic abnormality in the UTI in the urinary tract. Sorry. So if you have a patient with abnormality in the urinary tract, like a horseshoe kidney, urethrovesical reflux, or whatever it is, Pseudomonas is the most likely cause of the UTI. Or if the patient is heavily antibiotic experienced or have had a lot of antibiotic courses. Okay, so remember that. That's really important. Type. Okay, so patients with recurrent Proteus infection, and we said Proteus is going to cause what? Stratified stone. Stratified stone is going to have a staghorn-like calculus that looks something like this. And basically this would be the kidney, so it basically will obstruct the kidney, leading to hydroureter, which is really bad. Okay, so remember Strutevite stones. Staghorn calculus is caused by Proteus mirabilis. Um, Lastly, we have through hematogenous infection. The most common cause of pyelonephritis through hematogenous infection is Staph aureus. The reason why it's not E. coli in this case, because E. coli is the most common coming from a urinary tract. If it's coming from the blood, most common infections that are happening in the blood or in the body is Staph aureus. So the most common would be here, Staph aureus. Okay, and I'm going to revise these organisms so you don't get confused, don't worry. So how do we diagnose? The way we diagnose is we do the same urine test, urine analysis, urine microscopy, and urine culture. What are we going to see on urine microscopy? We're going to see the WBC cast. Very, very, very important to remember. WBC cast equals pyelonephritis until proven otherwise. Okay, so let's summarize the organism. E. coli, what do we need to know about it? Most common organism causing all types of UTI. Type 1 fimbriae is used for the adherence or the attachment. P. fimbriae leads to upper UTI. Okay, so these are the facts you need to remember at E. coli. ESBL, what do we need to remember? We need to remember the 5 millimeters. Okay, we need to remember that it's difficult to treat because of beta-lactamase. For Pseudomonas, what do we need to remember? We need to remember it's the most associated with pyelonephritis in patients with structural abnormalities in the urinary tract or extensive prior antibiotic exposure. Moving on, we have Proteus mirabilis. We need to remember high urease activity. This high urease activity will lead to Strutevite stone. And chronic catheter use, like chronic catheter infections by Proteus mirabilis, will lead to obstruction. Then we have Staph saprophyticus. I know I didn't mention it during the lecture, but I put it here because it's important to remember that happens in young sexually active females. However, if they bring a case of young sexually active female and they say what's the most common organism causing this UTI, if E. coli was an answer, answer E. coli. If E. coli was not a choice, answer Staph saprophyticus. Type. Staph aureus, what do we need to remember? Hematogenous spread. I'm going to pause for 1 second. Okay, I'm back. So let's start doing some questions. Okay, according to the following picture, which of the following indicates are the indication for the following procedure? So what this procedure is basically is a suprapubic tap, okay? And if you remember what we said about suprapubic tap is important for which of these following? I'm going to give you a second. Okay, so the answer is neonates. So suprapubic tap always associated with neonates. Next question. What factor of the bacteria is responsible for the appearance of mucoid colonies? I know this was not mentioned in the lecture. I just want you to know it, okay? Because sometimes they ask it. Okay, so just know it. Okay, so mucoid colonies is associated with capsule, so just memorize that. Okay, what would you tell a woman when collecting a urine sample? Okay, so we said when we want to collect a urine sample, we want to do which type of sample? Okay, so the answer is midstream sample. So the way you say void midstream in the bottom. So whenever you see the word midstream, know it's the right answer. Okay. Type. A patient with catheter-associated urinary tract infection presents for treatment. What is the most appropriate management? So how do we treat catheter-associated urinary tract infection? I'm going to give you a second here. And the answer is A. We remove the catheter and we give antibiotics. Okay. Next question. A 25-year-old pregnant woman has asymptomatic bacteria due to E. coli. What is the best management? So we said if there is a pregnant lady and she has asymptomatic bacteria, do we treat or do we not treat? We said if it's asymptomatic bacteria, we always treat. So the answer would be start oral antibiotic and repeat culture. I know like there's like also single dose antibiotic, IV antibiotic, placental antibiotic, but just memorize this answer. Okay. And just to explain, to make it easier, guys, for you to remember, is that it's asymptomatic. Usually asymptomatic stuff we don't need to treat with IV antibiotic. IV antibiotics are very aggressive, and the reason we repeat the culture is we make sure that the infection is not there anymore, so you won't harm the baby. طيب. Moving on, a hospitalized patient with long-term catheter develops UTI. What's the most common organism? So, with your eyes closed, whenever you hear what's the most common organism, unless there's something in the case hinting towards something, what do you answer? E. coli. And that is the right answer. Right. Our urine culture shows oxidase positive green colonies. Okay, this was not in the lecture, but this is from your knowledge from before, and could be asked because sometimes they ask it for some reason. So green colonies, oxidase positive, is which organism? It's Pseudomonas. And the answer is colored green. But that's all the answers. Okay. A newly married woman with UTI, what's the most likely cause? Okay, most likely cause. As soon as I hear most likely, E. coli, unless there's something else. So there's nothing special here. So E. coli, let's me search. Oh, there's no E. coli. So what do we look for? We said newly married, sexually active, young female. What's the most likely cause? Staph saprophyticus. Okay. Right. Sexually active woman with recurrent UTI, what's the best prevention? And this is more clinical, less micro, but I would know it. The answer is prophylactic antibiotic therapy. Okay. Here we have another question. A 7-year-old female is taken to the urgent care clinic, fever, periodic incontinence. So the pediatrician suspect a urinary tract infection. What is the most likely etiology of this child's infection? So, what's the most likely etiology of a UTI? Always the answer is what? E. coli. Okay. During a gynecological office visit, a positive leukocyte esterase test, along with avoiding urine symptom. I'm not going to read the whole case. I'm just going to tell you what's important here. I'm going to tell you that basically this person has a UTI. Which of the following is a virulence factor that's important for this uropathogen? Okay, so if you have a UTI, okay, and we know it's so it ferments lactose is basically saying it's E. coli. So which of the following? So what did we say is a virulence factor for E. coli? We said is a fimbriae, which allows for the attachment. Okay. Patient presents with recurrent urinary tract infection. I'm sorry if I'm going through this fast. I just don't want to take a lot of time if you're doing the review. But you can pause before I answer. So they have Proteus mirabilis in the urine culture. And remember what we said, Proteus mirabilis, we said high urease activity. This high urease activity will lead to more kidney stone. What type of kidney stone? Stratified. Okay. Which of the following is the most frequent cause of uncomplicated UTI? Community-acquired UTI, and we said it's always E. coli. Which virulence factor, uropathogenic E. coli, is most important for the adherence of uroepithelium? We already explained this and talked about this. It's fimbriae. Which of the following virulence factors is associated with pyelonephritis or upper urinary tract infection? P. fimbriae. Don't be confused and answer type 1. No, the answer is P. fimbriae. P for pyelonephritis. That's how to remember it. P for pyelonephritis. Which organism is most commonly associated with catheter-associated urinary tract infection? As you guessed, most common, always answer E. coli unless proven otherwise. Which statement describes sterile pyuria? So what is sterile pyuria? We said it's WBCs and no bacteria. So let's see. Bacteria, wrong. Protein in urine, no. RBC cast, no. Numerous RBC, no bacteria. That's the answer. Sterile pyuria is classically associated with which of the following conditions? So we said there are two main causes. The first one is genitourinary TB, and the second one is chlamydia. Remember both of them. What is considered the golden standard for bacterial UTI, confirmation of bacterial UTI? I want you to remember there is a golden standard and there is an initial. Golden standard here is a urine culture, okay? And urine culture showing more than 10 to the power of 5. What's the most initial? It's urine analysis or urine dipstick. Usually it's either or both of them are present in the same answer. Type. Which of the following tests, which of the following best indicates an ESBL producing strain enterobacter? Okay. So basically it's asking about ESBL, and we said if you don't understand what I explained about zone of clearance, amoxiclav, or clavulonic acid. Just remember the number 5. So this question basically, an easy way to answer is look at this number 5 millimeter, and you already know that the answer is B. Even if you don't understand what inhibition zone around cephalosporin increases with clavulanates. If you understand it, it's good. If you don't understand, just go with the one with 5 millimeter and more. But which of the following best defines asymptomatic bacteriuria in adult women? So we said asymptomatic. What's the number that we need to know? Is 10 to the power of 5. So let's search. Is 10 to the power of 3, so that's wrong. So 2 consecutive clean catch culture, 10 to the power of 5, so this has the answer. This one does not have 10 to the power of 5, so this is wrong. This is wrong. So the answer is B. Which organism is most associated with pyelonephritis in patients with structural urinary tract abnormalities or extensive prior antibiotic use? So there is a specific criteria here. They're not just saying UTI. So what's the answer? It would be Pseudomonas. Very important to know. A 30-year-old pregnant lady with a 24 weeks of gestation has bacteriuria with E. coli. Which of the following physiologic change in pregnancy is responsible for UTI? So we said it's because of progesterone, leading to hyperperistalsis, leading to stasis, leading to UTI. So the answer is B. Okay, this is an AMBOSS question. To summarize the question, is basically someone with UTI, and the gram stain shows no organism. Okay, so we have sterile pyuria. Which of the following is the answer or causative pathogen? The answer would be chlamydia. Yeah, so the answer is chlamydia. In this case, we have recurrent nephrolithiasis. Okay, so recurrent stones. Okay, and we have ammonia odor. Okay, so what we're thinking, if we have recurrent stones, the most common cause of recurrent stone, it would be Proteus mirabilis. Okay, so the answer would be, so if it's better to know gram negative, oxidase negative, but usually they will just bring Proteus mirabilis, which is pretty easy to answer. Okay, I think this is the last or second to last AMBOSS question. 24-year-old woman, nausea and weakness, high fever, costovertebral angle tenderness, which is flank pain. I forgot to mention in the lecture, costovertebral angle tenderness equals flank pain. They're the exact same thing. If you have that and you have fever, which of the following is the likely cause of this patient's condition? So we know that this patient has pyelonephritis. Okay, and how does pyelonephritis most commonly happen? An ascending infection from the bladder. Okay. But yep. Okay, so this question is talking about a woman with costovertebral angle tenderness, WBC cast. Remember, WBC cast is the most important thing to remember. So a biopsy of the kidney will show what? This is very like weird way to ask about the question, but if you have an infection in the kidney, what do you expect to find in the kidney? You're gonna see WBCs in the tubule. Okay, so the answer should be B. You shouldn't know this. I made sure to put all the AMBOSS questions that are related to the topic. If you don't know this, it's fine. Okay, so moving on to prostatitis. Prostatitis is basically infection in the prostate, and we have 4 main classifications. We have acute bacterial, chronic prostatitis, or chronic pelvic pain syndrome, and asymptomatic inflammatory prostatitis. But let's take one by one. Acute bacterial, it's tender, very painful to the patient, and the gland would be boggy. There would be fever and urinary symptoms. Okay, so usually they would describe it as someone with tender, boggy prostate with fever. Tender, boggy prostate with fever, it's acute bacterial prostatitis. Chronic bacterial prostatitis, it would be someone who's having recurrent bacterial infection, and they're having some like mild symptoms like dysuria or pelvic discomfort. Okay, and this recurrent infection usually happens with the same organism. Okay, so recurrent infection with the same organism and like mild symptoms like dysuria or mild like pelvic discomforts. So this is chronic bacteria. Chronic prostatitis, okay, or chronic pelvic pain syndrome, it's not an infectious disease, it's an inflammatory disease, okay, and it's basically more than 3 months. The culture is negative, but there is like inflammation, so there is like a pain in the pelvis, okay, so patient is complaining pain in the pelvis or pain with sexual intercourse, or with urination, but there is no positive culture, okay. Lastly, we have asymptomatic inflammatory prostatitis. So it's basically, sorry, so there are no symptoms, but there is inflammatory cells. Okay. So that's all you need to know. It's no symptoms, but there are inflammatory cells, and usually this is found incidentally, because no one is going to go if they don't have symptoms. So it's usually found incidentally for some other reason. Okay, and prostatitis usually is by definition inflammatory cells that are present in prostatic secretions or in urine, or in urine. Type. Prostatitis can sometimes happen in young adults due to gonorrhea or chlamydia as an STI or sexually transmitted disease. But the most common cause of prostatitis would be E. coli. Somewhere, it's going to be somewhere here, but just remember the most common cause of prostatitis is E. coli. It's not chlamydia or Neisseria. Usually happens the same mechanism, ascending from the urethra all the way to the prostate. Sometimes can happen as a hematogenous seeding or direct inoculation if someone is taking a biopsy from the prostate or doing a procedure in the prostate. Now, these are some like risk factors, but what I want you to remember is E. coli is the most common cause of prostatitis. This is a summary table. You can go through it at your own pace. So how do we diagnose? This is very important. Okay, let's start with acute bacterial prostatitis. Acute bacterial prostatitis we diagnose from the patient's clinical presentation. So what do? We do examination for the patient. As soon as you do a prostate exam, the patient will jump screaming out of pain. Okay, and when we do the urine culture, or not urine culture, sorry, urine analysis and urine culture, you'll see significant bacteriuria. Okay, so if you have a tender boggy prostate plus presence of significant bacteriuria, it's acute bacterial prostatitis. Very important to know that we do not massage the prostate for secretions. Only for acute bacterial prostatitis, we don't do that. Why? Because I told you, as soon as you touch it, the patient will jump out of pain. So if you do it, you massage the prostate, the patient will actually pass out of pain. Okay. And same as other UTIs, it's a midstream specimen that we collect for the urine. For chronic prostatitis, it's the same thing. Symptoms, and we check the urine sample. Urine sample will show a recurrent UTI of the same pathogen. We have something special now. We have urinary tract localization studies. Okay, this is not really done. I'm going to skip this slide. Here it is, qualitative or quantitative localization culture. I don't know why my mouse is doing ECGs. Crazy. And this is basically the diagnostic standard. So standard, golden standard of diagnosis for prostatitis, like chronic prostatitis, is this localization study. Essentially what it is we collect the specimen, which is basically, so the VB1, which is the voiding, I think voiding bladder, voided bladder. Okay, VB1 basically is the sample of urine in the urethra. Okay, VB2 is a sample of urine in the bladder. And then we have EPS, which is the expressed prostatic secretion. So after you massage the prostate, it releases secretions. Okay, and you collect these secretions here. And then after you collect these secretions and urinate, you'll have VB3, which is the prostatic secretions plus the urine in the bladder. Okay, so here it is in words. The first 10 milliliters of voided urine is basically VB1, which is the urethral urine. Very important to know these, by the way. Midstream urine sample is the bladder urine. And then after the patient urinate, we massage the prostate, okay, and we get the EPS, okay. And then after we get the EPS, the patient voids again, and we collect urine plus the EPS, which gives us the prostatic secretion, which is VB3. Very, very important to know this. I'm going to repeat it one more time. VB1, urethral urine. VB2, bladder urine. EPS, prostatic secretions, and VB3 is the prostatic secretion plus um, the urine in the bladder. طيب. How do we interpret the results? So when is it positive? It's positive when VB1 and VB2, okay, sorry, let's put it another way. When EPS or VB3 have 10 times the bacteria that are in VB1 and VB2. Okay, so let's look at it here. So the diagnosis of prostatitis happens when the number of bacteria in EPS is 10 times that of VB1 and VB2. Now, if we don't have EPS, sometimes the prostatic secretions are not enough, so we need to do the VB3. We check the VB3. The same thing, 10 times greater. Okay, so remember, if VB3 or EPS are 10 times greater than VB1, VB2, that's basically suggests the diagnosis of bacterial prostatitis. And this method, again, is the golden standard for the diagnosis of prostatitis. So let's do some questions. So what is the contraindication in the management of acute bacterial prostatitis? The answer is prostate massage. And remember, because the patient will scream out of pain if you do it. So we don't want to do that. We should absolutely avoid it. Okay, what is the most common route by which the bacteria reach the prostate in bacterial prostatitis? Same as all the UTIs, ascending infection. All right, which organism is the predominant pathogen in bacterial prostatitis? Predominant pathogen in UTI, what do we say? E. coli. Type. Which of the following confirms chronic bacterial prostatitis using, this is Mears STAMI is basically the same method I just talked about. This is the 4-glass test, is basically the same method I talked about. So how do you confirm the diagnosis? We said EPS or VB3 10 times higher than VB1. Let's search for it. This is not the answer. This is not the answer. So this is the answer. Okay, in Mears STAMI localization test, which of the following, or which sample presents bladder urine? So which one did we say bladder urine? VB1 is urethral urine. VB2 is bladder urine, so that's the answer. EPS, prostatic secretion, and VB3 is prostatic secretion with the voiding of the bladder. Which category of prostatitis is typically discovered incidentally? Okay, so we don't have symptoms and we don't have, we just have inflammation. So what is the answer? Asymptomatic inflammatory prostatitis. Okay, so let's do an amboss question here. To summarize the question, it's a 59-year-old man presenting with urinary symptoms and perineal pain. Okay, when we did a digital rectal examination, there was a swelling and exquisitely tender prostate. Now, when we hear exquisitely tender prostate or boggy prostate, we immediately think of what? Acute prostatitis. Okay, acute bacterial prostatitis, what's the most likely common cause? E. coli. Which of these are representative of E. coli? So it's gram-negative, lactose fermenting, pink colonies. Okay. I don't know if you need to know this, by the way, but E. coli is the most common cause of prostatitis in men over 35. Less than 35, it's chlamydia and Neisseria, but I don't think they're going to ask you this. This is too advanced. Type. Now we're going to talk about schistosomiasis or schistosomohematobium. Okay, so there are trematodes, and these are some fun facts that I wouldn't want to know. Okay, so schistosomohematobium is the most common cause of schistosomiasis, and usually they will tell you that someone came from Egypt or some part of Africa, and they were like in the Nile River or somewhere in the beach. So what's the life cycle? Before we talk about lifestyle cycle, let's talk about important stuff to know. These stuff are really important to know. So the parasitic agent obviously is Schistosomohematobium, okay, which is a trematode. The site of the adult worm, where does it stay in the human body? It stays in the venous plexus of the urinary bladder and lower ureter. Very, very, very important to know this. For step 1, for step 2, for your exam. The intermediate host is the Pyelonephritis species snail or freshwater snail. I would memorize or recognize it in the exam. You don't need to memorize it exactly. Just know freshwater snail and Pyelonephritis species or whatever this is. And the definitive host obviously is the human. Otherwise, why would we care? Type. So how does the life cycle? So someone goes to the beach, they're swimming, okay, and they're barefooted. So what happens is that we have something called freshwater cercaria, okay, which is basically the infectious, okay, freshwater cercaria is the infectious, remember this, infectious stage of schistosoma. It will penetrate healthy skin. It does not go through a wound, healthy skin, okay? And then it will transform into schistomules, okay? So again, I'm going to repeat this. We have cercaria, okay, freshwater cercaria, the infectious stage, transforming into schistomules after it penetrates the healthy skin. These schistomules will enter the circulation, and guess where it's going to go? It's going to develop into adult worm. And where did we say the adult worm stays? In the venous plexus of the prostate and lower ureter, also in the rectum and uterine, like these venous plexus basically. Okay. So to repeat, infectious stage is cercaria, penetrates healthy skin, transforms as schistomule, schistomule grows into adult, adult goes to the venous plexus. Right. After that, eggs are laid in the venous plexus. These eggs go to the urinary bladder, okay, and these eggs basically they're released they're released through urine, and these eggs will hatch, releasing mercedia, okay, which will repeat the cycle by penetrating the snail, okay, grows in the snail into what? Grows in the snail into the cercaria. Then the cercaria will penetrate the healthy skin, and then develop into schistomule. Schistomule will grow into the adult worm. Adult worm lays the egg. The egg go to the prostatic through the prostatic venous plexus to the urine. The urine will basically these eggs will hatch into mercedia or whatever it's called, infecting the snail, repeating the cycle. You get the point. What I would remember from this is this: cercaria is the infectious state, okay, and it's penetrating normal, healthy, intact skin. The schistomule goes to the prostatic venous plexus, very important to know, or the lower ureter or the rectal venous plexus, okay? And for better understanding, why do we care about the egg migrating to the bladder? Because this egg migrating to the bladder will cause formation of granulomas, okay? And this will lead to chronic infection and chronic inflammation, and can lead to malignant transformation. Okay, so here it is. So egg deposition is going to lead to granulomatous inflammation. This chronic inflammation is going to lead to ulceration, fibrosis, calcification, and chronic inflammation usually in the body is going to lead to what? Neoplastic potential. And in this specific case, it's squamous cell carcinoma of the bladder. Very, very high yield to know this. Schistosoma hematobium, chronic schistosoma hematobium infection will lead to squamous cell carcinoma of the bladder. Okay, and it's very important to know if we have someone that presented to the clinic with squamous cell carcinoma of the bladder, the most likely cause is schistosoma hematobium. Otherwise, it would be urothelial carcinoma, which is caused by smoking. But so the most common type, and just to tie it clinically, the most common type of bladder cancer is urothelial, caused by smoking. The second most is squamous cell, caused by schistosoma. Type. Clinical presentation, how does it present? It presents with allergic reactions, hematuria, bladder scarring, which leads to loss of bladder capacity, obstructive uropathy, and the most important one to remember is squamous cell carcinoma. I would remember this out of all. Type. How do we diagnose it? We diagnose it through looking at the urine sample, the very end of the urine sample. There usually will be parasitic eggs. So there will be parasitic eggs in the last few drops of the urine sample. And finding the eggs is basically the golden standard of the diagnosis. Okay, so how do we diagnose? Final bit of the urine basically will have parasitic eggs, and the presence of these parasitic eggs are the golden standard of diagnosis. And here we can see these are basically the schistosoma hematobium eggs. Okay, and the terminal of it is at the head of it. I don't know if you need to know this or not from pathology. I don't remember anymore. Okay, how do we manage? The drug to manage it is praziquantel. Okay, Just remember that drug. It's really important to remember, I guess, for other lectures, not for micro, but just remember presenquintal is a treatment for schistosoma. What are some of the complications? Again, very important to remember, squamous cell carcinoma. Malignant transformation happens because of chronic inflammation, leading to squamous cell carcinoma. Okay, let's solve some questions for schistosoma hematobium. Okay, what is the mode of transformation of schistosoma hematobium? Okay, is it airborne? No. Is it ingestion of fish? No. Mosquito bite? No. We said it's penetration of healthy skin. Again, it's doing the ECG stuff. But what is the infective stage of schistosoma hematobium for humans? We said it's Sarcaria. And if there's one name I would remember from all the cycle, it would be Sarcaria. If it's difficult for you to remember all of them, just remember Sarcaria. Right. What is the intermediate host of schistosoma hematobium? What did we say? Is it freshwater fish? No. Is it dogs? No. Is it sandflies? No. It's freshwater snails. Bulinis, or whatever the hell is this. Right. In which location are adult schistosoma hematobium worm typically found? So where do we find them? So we said venous plexus of the urinary bladder and the lower ureter. What's considered the golden standard for the diagnosis? We said the eggs that are found in the urine. So let's see what's answer for matching with this. ELISA, no. Stool microscopy for the ova, no. This is trying to trick you. It's an egg, it's not an ova. PCR from blood sample, no. And finding terminal spined eggs properly collected in terminal urine, yeah, obviously that's the answer. Which serious long-term complication is specifically linked to chronic schistosoma hematobium? Very important to know. And the answer would be squamous cell carcinoma of the bladder. What is correct regarding schistosoma hematobium? Okay. Finding the eggs in the urine is golden standard. That is correct. Okay. So this is the amboss question. Okay. Someone comes, there is a granulomatous inflammation. Someone comes with loose stool, They have granulomatous inflammation of the with periportal fibrosis. So this is a different type of schistosoma. This I don't know why I included it. My bad. But yeah, it's basically schistosomiasis. This is schistosoma, but it's not hematobium. I think this is a different type. If I'm correct, yeah, this is schistosoma massonii. I don't know if you guys need to know this, but either way, what I would remember is which one is the host. It's the freshwater snail, and we already talked about. So there's this one question I wanted to go back to. This question is talking about. It's very important actually. Basically, oops, I should answer. So basically we have here with clavulanic acid 21 millimeters, okay, and here without clavulanic acid 14 millimeters. So if we subtract it, it's 7, yeah, 7, which is more than 5 millimeters. And we said when it's more than 5 millimeters, it's ESBL. So the answer with ESBL is A. So what basically this is trying to say is basically here we have beta-lactamase inhibitor, which basically inhibits the beta-lactamase of the bacteria, inhibiting the growth of the bacteria. That's why we have a bigger zone of inhibition or zone of clearance. So yeah, remember this question is very important. Okay, I'm back. Turns out I'm not gaslighting myself. I remembered I need to do the QR code. So please, if you can scan the QR code, give your feedback for the lecture so I can improve inshallah next time on whatever feedback you give. Thank you guys, and I wish you all the best on your exam. Inshallah, you'll do all amazing. If you have any questions, let me go to the slides 1 second. Yeah, you have my number and you have my email.